All right, this morning we're going to talk about endocrine and acid-base disorders. We are not, don't worry, going to talk about all the pathophysiology and all the loops and all that stuff that you read about. We're going to talk about some really practical approaches to some common endocrine disorders that we see very commonly. All right, so let's start off talking about the most common of all things that we're going to see in the ED, which is diabetes. Diabetes, the prevalence is very high. We know in the United States, about 1 out of every 10 patients will have diabetes, hyperglycemia. There are studies showing that if we keep things up with sort of our diets and childhood obesity, that those numbers may increase up to 25% as this generation of children become adults. 20% of folks that have diabetes actually don't know that they have diabetes, which makes it a really, really important thing for us to be able to recognize in the ED. Here's some of the symptoms, some of the things that we may see in patients that are presenting for other things, but may be hyperglycemic. What are those symptoms? Well, you probably hear about these all the time. People that come in complaining of, I'm having increased urination. They have increased glucose in their body. They start to urinate more. I am more thirsty than usual. They may be having more yeast infections, recurrent yeast infections, things like that. Any of those things sort of pop up in your review of systems, we've got to be thinking about hyperglycemia. Now, your run-of-the-mill hyperglycemia, those are patients that can typically go out and be referred to primary care. I think it's really important that we think about it, that we identify it and let patients know to be followed up to get proper treatment. However, the one condition that we as emergency providers must be intimately familiar with is diabetic ketoacidosis. Now, what is it about this specific disease that differentiates the typical hyperglycemic? Somebody has high blood sugar, they can go to primary care. Somebody comes in with this, they need to go to the ICU. What is the big difference here? Well, first of all, this tends to happen almost exclusively in type 1 diabetics. This is a disease that occurs because type 1 diabetics do not have insulin, and because they don't have insulin, when the sugar starts to go up and they start to have osmotic diuresis and they start to get dehydrated, their cells can't get any of that sugar. Right? The cells require that sugar as fuel, and because they don't have that sugar as fuel, they pee, and then they pee out and get dehydrated. They pee out their electrolytes, their potassium and phosphate, and ultimately the cells are sitting there being, man, I need some sugar. So because they can't get it from the carbohydrates, the clean fuel that they need, we need to switch over into a different type of metabolism, which is fatty acid metabolism. They start to go after that for fuel. So our body starts to go into lipolysis, fatty acid metabolism, ultimately leading to keto acids being developed. And that is not the clean fuel that our cells crave. This is sort of like a bootlegged fuel. This is kind of a fuel that if you have to use it, you use it, but you don't want to. And the cells, when they start using those keto acids, you start to develop all sorts of symptoms and complications. So the clinical manifestations of DKA are largely related to the dehydration. They pee everything out, they get dehydrated, you get dry mucous membranes, but then all that dehydration starts to make them feel pretty crummy in their stomach, they start to get nauseous, they start to vomit. And then you get the keto acids kind of kicking in, and the keto acids put your body into this acidemic state. And when your body's in an acidemic state, it tries to compensate. One of the ways it does that is respiratory. So if you see that diabetic patient who's in your ED and they're doing this kind of pattern, this fast and deep respirations called Kussmaul breathing, that should be highly concerning for somebody having DKA, someone who's very dehydrated and has that type of breathing pattern. They're trying to blow off those keto acids. There's certain people that can actually smell the ketones. Has anybody ever seen a DKA patient and you can smell the ketones? Okay, I am fortunately one of those people that can't smell anything. My wife, if my kid, my 3-year-old, he poops in his diaper from 2 rooms away, she can, our kid pooped. He'll be right in front of my face with his butt right here, and I don't know. And I am actually very grateful to not have that superpower in our emergency department. I can't smell ketones. I can't smell a lot of things. Very protective. But these patients they're trying to blow off the ketones. Some people can smell it, some people can't. And then they can get lethargic from all of the dehydration and a few other things. Now, they get all of these symptoms in the setting of type 1 diabetes. The other thing that's really important is not just to identify that they have DKA, but to identify why they have DKA. Let's go back here. And the causes of DKA. Now, we're going to talk about a few different endocrine emergencies. We're going to talk about thyroid. We're going to talk about some acid-base stuff. Almost every endocrine disorder, the disorder gets worse when you have an acute stressor, and the DKA is exactly in that same vein. So in DKA, the things that cause DKA, the eyes, that's sort of the thing we use to think about, like, what are the causes of people getting DKA? And they're all the things that you could think about as acute stressors. Infection, here we have infarction, acute MI, infraction. I don't think of it it's non-compliance, but I just think insulin instead of infraction. And then infant, which is pregnancy. So if they have any of those things and then any other slew of acute stressors, any of that can kick somebody into DKA. Why? They already don't have enough insulin. Then you add the acute stressor, which increases their metabolic demand. They can't meet that metabolic demand. So then how do we test for it? So the very first thing, the most important of all things for a patient with potential DKA is, how do they look like clinically? If a person is coming in with type 1 diabetes and they just look ill, they look dehydrated, their mucous membranes are dry, they have that breathing pattern we're talking about, that's clue number one. And then we need to investigate some more through their labs. What type of lab findings are we going to find? Here we are. The first thing is you want to look for an elevated blood sugar. Typically, diabetic definitions include a blood sugar greater than 250. So you really need to have a blood sugar greater than 250. There's one really, really important exception here is people that are on these SGL2 inhibitors. If you guys have ever seen these are the Flozin meds. They all end in something Flozin. These medications cause you to pee out all of your glucose. They kind of get rid of your glucose. So they prevent glucose reabsorption in the kidneys. You pee out all the glucose. So they end up not having these high sugars with their DKA. They can have actually normal, lower sugars, but still develop DKA. So it's really important to recognize that. We're seeing more and more patients on those medications. But in general, you want to see that the patient has a high blood sugar. In addition to the high blood sugar, they should be acidemic. So we look for, on a VBG, metabolic acidosis. They really need to have a low pH, less than 7.38, and they need to have a low bicarb. So those are important measures. And then beyond that, you want to not just make sure that they're acidotic, but they have an anion gap acidosis, because diabetic ketoacidosis is an anion gap metabolic acidosis. And the way that you calculate that is sodium minus the combination of your chloride plus your bicarb. Okay? So check the sugar, that's high. Acidemia, their bicarb's low, their pH is low. And 3, their anion gap is high. Those 3 things really need to be part of the definition unless they're on those SGL2 inhibitors. And then the potassium is critical to check. It's not critical in terms of diagnosing DKA, but it's critical when we start to think about how we're going to treat DKA. We really need to have a great idea of what their potassium is. One of the ways that we can really, really harm patients with DKA is lowering their potassium too fast. We'll talk about that in the treatment part in a couple slides, but just keep that in the back of your mind, all right? And then we can check their urine. In the urine, you can sometimes see ketones and stuff on a U-dip. Really nice, can kind of give you a clue that they may be in DKA when that's positive. All right, other tests. So the first thing we do with DKA patients is try to identify whether they have DKA or not through all the things that we just talked about. There's 2 other things that I look for in the labs in my DKA patients. Number 1 is there an acute stressor that I can identify, one of the eyes? So all of these things is there an infection? I'm going to be checking their UA, check their chest x-ray. Did they have an infarct? I'm going to check their troponin. And then you want to look for potential complications of the DKA. Somebody in really, really bad DKA may develop renal insufficiency, may develop a renal failure, and have other complications from the DKA. So you want to look at both sides of that equation. One really interesting lab finding in DKA is this concept of pseudo-hyponatremia. So you have somebody with a really high blood sugar that comes in, and you look and their sodium something in the 120s. And that is called pseudo-hyponatremia, not because it's like fake that they have like low, it's actually, they have, the sodium is still there. It's not fake hyponatremia, but it's a diluted hyponatremia. Why is that? So when you have high blood sugars, that blood sugar gets into the serum, and then fluid follows that. And then as that fluid follows the sugar, it starts to dilute the sodium that you have in your serum, therefore causing a pseudo-hyponatremia. How do we account for that? Whenever you see a low sodium in the setting of somebody with a really high blood sugar, this is the calculation. I don't want you guys to memorize this. You can go on the computer anytime during a shift and look this up. But in general, every 100 of glucose that you elevate, it will correct by about 1.6 of sodium. So it's falsely low about 1.6. So if you have somebody with a blood sugar of 600, their actual sodium will be about 8 to 10 above the actual lab reading. So if you can imagine somebody with a sugar of like, say, 600 and a sodium of 145, you may say, hey, that sodium is actually normal. But then when you correct, that person actually has pretty profound hypernatremia, which signifies pretty significant dehydration. Something to just keep in mind. All right, diabetic ketoacidosis initial treatment. I think about the treatment of DKA in a couple of different phases. The very first thing is these patients come in pretty dehydrated. They can be up to 8 liters to 9 liters fluid down from their dehydration and all the osmotic diuresis. So the very first thing to keep in mind with DKA is to just rehydrate them. The second thing is to address their electrolytes, if their potassium is low, things like that. And the very last thing that we think about, which you think, hey, let's get the insulin on board right away. Keep this in mind with your DKA patients. Never reflexively go for the insulin right away, because it is the one way that we could harm patients rather than help them. Okay, our whole job, first do no harm. This is the way that we could actually hurt our patients. Remember, insulin drives down your blood sugar and also drives down your potassium. So if you're starting with a low potassium and you hang that insulin, you could get them into a pretty bad arrhythmia and have problems. Now, in terms of the concept of giving insulin to bring down the blood sugar, a lot of people, when we talk about giving insulin for blood, they think, hey, like, I'm giving insulin to bring the blood sugar down. That's not the reason we're actually giving the insulin. The reason we're giving the insulin is that you have too much blood sugar in your serum and it's in the wrong place. We want to take all of that blood sugar and put it into the cells where it belongs so that it can use it as fuel. So when you think about your treatment of DKA using insulin, all you're doing the entire time is pumping in insulin to take that substrate and put it into the cell where it belongs. It's like being at a gas station and not having a hose to put the fuel inside your car. That's what the insulin does. It's the hose. It takes all of that fuel and actually puts it where it needs to be inside the vehicle, which is your cells. All right? So again, first, rehydrate the patients. 2, replenish any electrolytes, the potassium, which we'll talk about again. And then 3, the last thing that we do is get the insulin on board to get the sugar into the cells and bring your acidemia down. It's not to bring down your blood sugar. It's to correct your acidemia, bring the blood sugar into the cells so they can get back to normal metabolism. All right, we just talked about this. Don't start until the potassium level is known. So you know that, I'll show you on a chart exactly what levels of potassium you should be replenishing and when to start your insulin and everything. But assuming that you have a normal potassium level or high potassium level, you can now start to use your insulin. You started at 0.1 units per kilogram per hour. So in a 70 kilogram person, you're going to be using 7 units per hour. And you're going to continue that infusion until your blood sugar gets to about 250. When it gets to about 250 or lower, you have to add a dextrose strip. Now, again, people get reticent about, why would I add sugar for a condition where the sugar is the problem? You have DKA. Why would I hang a dextrose strip? And this just goes back to that original concept, which is that they need the substrate. So there are some really brittle diabetics that'll start with a blood sugar of 300. And so almost immediately, you gotta, as you're hanging your insulin drip, you gotta hang the dextrose at the same time in order to give them the substrate to get that fuel into their cells, okay? And then the BMP really needs to be checked every 1 to 2 hours. We have VBGs at our place, so you can get these more point of care things, but we do, like at our shop, we'll do BMPs every 2 hours and we'll alternate every hour doing a VBG. And why do we do that? Because it helps us understand where our bicarb is. So you're really tracking that bicarb and to make sure that the acidemia is getting better. You want to track where your potassium is to make sure you're replenishing the potassium, and you want to make sure that the anion gap is going the right direction. And of course, the blood sugar, making sure it's not going too low. In terms of the fluids that we're using for DKA, we talked about hydrating. One of the really important things is to not make them more acidotic with your fluids. And which fluid can make you more acidotic? Normal saline. When you have normal saline, you have high loads of sodium and you have high loads of chloride. And chloride, when it combines with hydrogen ions, can cause acidemia too. It's just a non-gap acidosis. So as you're trying to fix your DKA and you're giving them fluids, you don't want to counter your efforts by giving them high loads of normal saline, which then can cause you to become acidotic. You can see this phenomenon where your bicarb starts to actually go down as you're treating with more and more fluids. So a lot of folks now are shifted, including myself, have shifted to using LR, lactated ringers. Lactated ringers has a lower chloride load, doesn't put you at risk for this hyperchloremic non-metabolic gap acidosis. Does that make sense? You're trying to close your gap, you're trying to fix your bicarb, don't give them fluids that'll decrease your bicarb and make you more acidotic. All right, here is a schema. I don't want you to freak out looking at this thing, but the key concept here is we talked about when you have a low potassium, you want to make sure to replenish it. So this gives you the ranges of potassiums to think about when you can and can't start your insulin drips. If you have a potassium level that's less than 3.3, absolutely do not start the insulin. We need to give them, replenish all of their stores of potassium. Remember we talked earlier about them peeing out all of this, you get the osmotic diuresis, you also pee out a lot of your potassium, so they deplete their potassium stores pretty significantly. If they have a sodium or potassium level that's less than 3.3, that means they are very, very, very depleted. Even when they have normal or high potassium in the serum, they're pretty low whole body. But less than 3.3, you got to give them oral, you got to give them IV potassium. Do not start the insulin until after those things are corrected. And then if you have that range from 3.3 to 5.0, then you want to give them that potassium along with your insulin. And if they have a potassium greater than 5, then you don't hang the potassium at all. Now we're talking about so many different drips. We're talking about giving them IV fluids. We're talking about potentially giving them dextrose. We're talking about giving them insulin drip. If they're infected on top of that, they may need antibiotics. So these DKA patients, one of the first things that we want to do is make sure they have multiple lines. And they don't always need a central line. Some of them do if they're really sick. But one of the very first things when these patients come into the ED is I ask the nurses, hey, make sure we're getting a lot of lines in because we're going to need fluids. We may need dextrose. We may need potassium IV. We may need a lot of different things. All right, so that's DKA. And those are mostly in the type 1 diabetics that you're going to see that. Okay? Now we're going to talk about hyperosmolar or hyperglycemic state. This is a non-ketotic problem. All right? These patients are type 2 diabetics. DKA can occur within a matter of hours to days. This problem, hyperosmotic hyperglycemic state, which tends to happen more in the type 2 diabetics, occurs over days to weeks. So what's the pathophysiology here for these patients? These patients also have really, really high blood sugars. In fact, a lot more blood sugar than you'll often see in DKA. Sometimes we'll see DKA with blood sugars 300, 400, 500. These patients, you'll see blood sugars in the 900s, thousands. I've heard of people with 2,000s, very, very high blood sugars. And the way that this happens is this tends to occur in sicker, older patients that have poor access to fluids. So they will start to get a high blood sugar from their diabetes. They'll also get the osmotic diuresis. They'll start to get really dehydrated. Then they'll start to get altered because of their dehydration, which further restricts their access to fluids, so they don't drink. They get more and more dehydrated, and then they come in with significant, severe hyperglycemia, and a lot of times with alterations in their mental status. They don't get ketotic, however. Remember, they still have some insulin stored, so some of that blood sugar is still getting into the cells, so they don't have ketosis, but they have really high osmols. And the reason for that is they're so dehydrated, there's so much sugar in their serum that it causes this sort of almost like hyper-concentrated, viscous, rock candy-like blood. So they just have hyperosmolality from that, often more than 350. And the treatment for these folks is, like we said, it happens over the course of weeks a lot of times. We have to rehydrate them, but we don't need to give them all their fluid back immediately. A lot of times these folks are 8, 10, 12 liters down, but we can rehydrate them. What I like to do is kind of rehydrate half of their volume in the first 12 hours and then the other half of their volume over the next 24 hours as an inpatient. So I just kind of calculate it out, give them some of that saline. These folks, because they're so dehydrated, often are very hypernatremic. And remember, you do your calculations with the pseudohyponatremia. A lot of these folks are really, really hypernatremic. So you also want to be careful to change over to half normal saline for these patients when they're hypernatremic. They also get insulin drips. But I tend to use, instead of 0.1 units per kilogram, I go to 0.05 units per kilogram, just to kind of correct them a little bit more slowly. When somebody comes in after having been dehydrated for 2-3 weeks, we want to match the tempo of our treatment to the tempo of the way that they develop their disease. This is another schematic of HHS, which just shows when they're hypernatremic, some of the ways that you can treat that. This is more of a reference slide, beyond the scope of this, how to deal with hypernatremia, but just recognize they may be hypernatremic as well, and these are some of the ways you can treat it. Okay, so that's high blood sugar. Let's talk about low blood sugar. Low blood sugar is something that we've all seen and we all talk about. Whenever somebody comes in, this is a big mimic of stroke. It's a big mimic of seizures. It's a big mimic of altered mental status. So anytime somebody comes in with these neuro complaints, seizures, stroke, altered mental status, or they're sitting in your ED and they develop any of those symptoms, the very first thing we should always do is check the blood sugar. And I can tell you, we talk about this in almost every lecture, and I've learned this as an intern and as a resident. I've talked about it as an attending. I've still missed this. I've had patient come into the ED with stroke, classic arm and leg weakness and all that stuff. We activate the code stroke. We're proud. We get the neurologist down. They might be a candidate for thrombectomy. And then the nurse asks, hey, did anybody check the blood sugar? It's like, did anyone check the blood sugar? Didn't EMS check the blood sugar? What was the blood sugar? And then they check and it's 35 and everybody's embarrassed. This will happen. This will happen in your career, but every time you have a seizure, every time you have a stroke, anytime you have someone who's altered, please, please, please check the blood sugar. Now, what are the symptoms that people have when they have low blood sugar? You guys have all seen this too. There's 2 buckets of symptoms that I think about. The first bucket is like the sympathomimetic type of things. You get all these counter-regulatory hormones as your blood sugar dips, and then your body's response is like crank up the epinephrine and all that. So you get tremors, you get anxious, you get sweaty, all those things. If someone's on a beta blocker, however, they won't manifest those things as well. So with our type 1 diabetics, people that are at like real risk of getting hypoglycemic, oftentimes docs will try to avoid maybe putting them on beta blockers so you'll know a little bit earlier. Somebody's on a beta blocker and they're insulin-dependent diabetic, like you may miss all of those early sympathomimetic symptoms. However, you have other symptoms, which are the neuro symptoms that are all here that we just talked about, seizure, stroke, all that kind of stuff. Ideally, you get some of the precursors to that. Now, there's 100 different reasons why somebody could be hypoglycemic. Okay, they can be adrenally insufficient, they could have sepsis, you can have medications that cause it. There's just a whole slew of things that can cause hypoglycemia. We're going to focus on hypoglycemia in the setting of diabetes. So diabetic type 1s, remember, they lack insulin. So when they get hypoglycemic, it's usually because they haven't taken they haven't taken their meal. So they've been taking their insulin, but they skipped their breakfast, for example, or they've been exercising. I have a good friend who does a triathlon with us every year, and he's type 1 diabetic, and he has his little glucose monitor, and after every sort of part of the race, he has to check, and he has to really calculate when to take the gels and all that stuff, so that even if he's taking the right amount of insulin, the exercise, the metabolism is too high for him to take that. So the treatment for these folks is pretty straightforward. It's dextrose. So ideally you give them oral, but you can give them IV dextrose D50, which is about 25 grams of sugar, which is about the same as a Snickers bar. You can also use glucagon, which if for whatever reason you can't get D50. And then you can also get hypoglycemic with type 2 diabetes. Now these patients have insulin, and so the reason that most of these folks get hypoglycemic is they're on a medication called an oral sulfonylurea, and those medications are the ones that end with Zide. So the glipizide, glyburide, those types of medications. And those medications can manifest with low blood sugar, and then it takes a while for that to clear when they're taking too many oral sulfonylureas. These patients generally need to be admitted. We give them dextrose IV, we can put them on dextrose strips. The other option for these folks is we can give them sub-Q octreotide. And giving them sub-Q octreotide will actually prevent insulin release, and then you repeat that every 6 hours. It's a nice thing to supplement these patients with if you're going to be admitting them for oral sulfonylurea overdose or ingestion. All right, that was diabetes, by far the most prevalent. We're going to switch gears to our friend the thyroid. Far less common. Now we have about 1 out of every 100 folks that we're going to see have thyroid disease, but it's important for us to be familiar with the thyroid. So the way that you remember, just a quick review of the pathophys. Up in the hypothalamus, you get thyroid-releasing hormone. That goes to your pituitary. That releases thyroid-stimulating hormone. Then that goes to your thyroid, and your thyroid releases thyroid hormones, T4, T3, which act in the periphery. Those are the ones. T4, it gets converted to T3. T3 is the really, really active form of it. And then everything happens from there. Now, when you have hyperthyroid, you have a lot of thyroid hormone going on, your TSH is going to be low. When you have hypothyroid, your TSH is going to be high. I think about it as sort of like a horse and a jockey. When the horse is going slow, the jockey is using that riding crop or the whip, like trying to make it go faster. And when the horse is like running really fast, there's no need to whip or whatever, so the TSH doesn't need to get released. Now, this is a green woman with symptoms of either hyper or hypothyroid. The way I think about hyper or hypothyroid is, if anybody's ever seen Winnie the Pooh, hyperthyroid is like the Tigger, hypothyroid is Eeyore. And hyperthyroid is your body is just revved up. You're getting tachycardic, you're anxious, your bowels are running fast, you can't sleep, your body is just revved up. And then when you're hypothyroid, everything is sort of sluggish. You could be bradycardic, you're tired, you're fatigued, you're constipated, everything kind of slows down. So let's talk about hyperthyroid and thyroid storm first. Hyperthyroid, all the anxiety symptoms, you could get tachycardic, those are all typical, so that's a typical hyperthyroid presentation, but thyroid storm is the emergency that we need to be familiar with. And the sine qua non, the kind of defining feature of thyroid storm is they get altered. They get febrile and altered for the most part. There's a whole scoring system called the Birch-Wartofsky scale that gives you like all the different ways that you can know that somebody's hyperthyroid, or has thyroid storm. But thyroid storm, the extreme version of it is really when they're altered. You can see this patient has big bulging eyes. This really only happens in Graves' disease. This is an autoimmune thing that can activate the antibodies behind your eye and proliferate. But just know for hyperthyroid and thyroid storm, almost all the problems emanate from the thyroid gland, and not so much from the pituitary. If you see new onset AFib, that's another clue that, especially in somebody with the other symptoms, that this may be thyroid related. I check a TSH and new onset AFib for the most part. How do we treat these? The first thing that you treat is treat everything peripherally and then work your way back. So for thyroid storm, you want to treat their symptoms first. They're going to be febrile, they're going to be altered, they're going to be tachycardic. So you want to give them IV fluids, you want to give them hydrocortisone because they can get a relative adrenal insufficiency. And then you want to give them beta blockers. Propranolol will decrease their heart rate, but it'll also block the peripheral conversion of T4 to T3. The T3 is the really active form, so it kind of blocks that. Then, once you've controlled their symptoms, then you move into blocking the actual thyroid itself from releasing methimazole, PTU, and then iodine an hour after that. But really in the ED, what we're mostly doing is supportive IV fluids, hydrocortisone, beta blockers are the first line of treatment, okay? One really, really important point for these thyroid storms, treat them with antibiotics. They're going to be febrile, they're going to be altered. You'd be thinking antibiotics anyway. So many of these are triggered by sepsis, so just make sure you're doing that as well. Hypothyroid, everything is on the opposite. They're sluggish, they're slow. They can come in with confusion, hypothermia, bradycardia. A lot of times they'll have a scar on their thyroid right here, so take a look for that. And if they have that, that is a clue that they've had some sort of surgery that's caused their thyroid to be low. The treatment there, again, supportive, warm them up, give them fluids, hydrocortisone for them as well, because they can also get adrenal issues, and then you give them the thyroid hormone. And then obviously correct any electrolytes. This is a patient with hypothyroid before and after treatment. Puffy. This is kind of what the look of a patient will be. You can see on the lateral third of his eyebrows that he's missing some hair over there. That is something that is like a clue that you could look for as well. Okay, now we're going to go through a really quick and dirty. I'm going to give you acid base in a couple minutes, like how to think about it. All right? So first of all, there's two primary ways that you can get acidosis, and that's respiratory or metabolic. There's a difference between acidemia and acidosis. Acidemia is what happens in your blood, so your actual pH, that's the emia. The acidosis or the alkalosis, that's the process that's driving that, okay? Then you compensate for whatever that is, either respiratory or through the kidney. The respiratory compensation can take minutes to hours, so you can compensate. If I have like pretty bad acidosis in my body, and from a respiratory standpoint, I can blow that off pretty fast. But if I'm compensating, when my kidneys are compensating for a respiratory problem, that can take hours to days, all right? You're going to check the blood gas, you're going to check the pH, the PCO2 and the PO2. These are all the things that you're going to need to determine your blood gas determinations and what's acidosis or not. Base excess, just 1 point on base excess. If you ever see this on your blood gas, if you have a negative base excess, that typically tells you your acidosis. If you have a positive, it usually tells you it's alkalotic, but it's really complicated by comorbidities, so you would only use base excess in someone with like no real comorbidities. Okay, from the ABG and VBG, you're going to want to look at the pH and the PCO2. From your chem panel, you're going to look at the bicarb and the anion gap. The pH and the PCO, so the PCO2 tells you what's going on in the lungs, the bicarb is telling you what's going on in the kidneys, and the pH is telling you which way you're going, acidosis or alkalosis. You have to know how to calculate an anion gap, so memorize this. And we're going to rip through just like an approach to how to do this. So the first thing that you're going to look at from your blood gas is your pH. That's going to tell you, are you acidotic or you're alkalotic? If it's less than 7.4 acidosis, more than 7.4 alkalosis. All right, the next thing we can check is the PCO2 from the VBG. If your PCO2 is low, that means that you're blowing off. That can tell you have a primary respiratory process. And if your PCO2 is high, then that tells you that you probably have a metabolic alkalosis, which would correlate with a low bicarb. So the great thing about all of these processes is if you have a low bicarb, your compensation is low PCO2. If you have a high bicarb, your compensation is a high PCO2. So we'll see that on the other side. If you're acidotic, PCO2 is low with metabolic, then if it's low, then that's metabolic, and if it's high, it's respiratory. I'm not going to go through all the compensatory calculations and everything else, but just recognize that every time you have a process, there will be a compensation for that, and you can go through that through going through that algorithm. Metabolic acidosis, there's anion gap and non-anion gap. It's really important to recognize the differentials for that. Anion gap, cat mud piles. So memorize this. Ketoacidosis diabetic is part of that, but know all the things that cause gap acidosis. That's when you just lose bicarb. And then non-gap acidosis is basically anything that causes renal or GI losses. So you lose bicarb and you lose sodium. So you're losing your cations and anions. Important to distinguish because the treatments are very different. Here's some more causes of metabolic acidosis. Again, renal and GI is mostly your non-gap. Metabolic alkalosis is addition of bicarb or loss of acid ions. And so here are some of the causes there for your reference. And then this is all reference slides. We're not going to go into a deep dive into this, but just recognize anytime you have an acidotic process, you're going to have a compensation. Anytime you have an alkalotic process, you're going to have compensation. Most important thing for you all to know is to recognize metabolic acidosis, know if it's GAP or non-GAP, particularly in DKA, treat it accordingly. And then when it's respiratory acidosis, that tends to be like your COPD patients or even patients with brain bleeds that aren't breathing fast enough, and they can have like a high CO2 from that, okay? So that is a lot of endocrine in a short amount of time, but a place to get you guys started.